Developments on COVID-19. Let's cross live to that briefing.
In terms of the daily cases. So I just want to show you very briefly what the flow looks like in terms of the data that does arrive at the NICD. Sorry, I think I've got my slides in the wrong order. Let me just stop. I apologize again for that little glitch, taking up your time. And this is really, there's a massive team behind all of this at the NICD, and they've been working all hours to try and ensure that that data goes out on a regular basis as you've received them every night or in the evening. So as I indicated, the specimens come from a range, or the cases that we report on are from symptomatic individuals that present for testing or are referred by a clinician, or an individual feels they've come into contact with someone who has COVID, or it could be asymptomatic individuals, again, either testing for travel purposes or returning to work, or again, may have come into contact with someone who they think or has actually tested for COVID-19 and tested positive. And so there are two main streams, if you like, for the data. This is both the public and the private sectors where the data comes from. And so, again, when that swab is taken, and some of you have already experienced that, a form is filled out, and that form contains various levels of detail that are required for capturing on the medical laboratory information systems. And of course, COVID-19 is a notifiable medical condition, and it was really critical that we collect this data and report on this particular data, not just for intervention purposes or management purposes, but also because it's a notifiable medical condition. So in terms of the data flow, so once the tests have been completed, it's entered into a laboratory information system, and there are different types of systems. The National Health Laboratory Service has what is called the track care system, and there are various other systems at the different private laboratories. What happens is that data then lands. The so-called ETL, and that is then collated and then sent on to be deduplicated. This is the test data. This then is deduplicated, so we can have an individual view of a person that has presented for testing. And of course, that it would include if this particular individual has had multiple tests, so we can get a sense of, for example, reinfections in terms, and Michelle will go through some of that as well, if possible. We then have the deduplicated data looking at all the positives, and this is used again to tell us what are the incident cases. It's used for modeling purposes by the South African COVID-19 Modeling Consortium, and of course there are also various quality checks looking for exceptions. If they're QA samples, the QA samples should be removed, and so forth. So that is what happens to the positives, and then we get the cases. So this is the full identified individual with his or her data, and that's used for the daily reporting. It's also used for geocoding, so we can look at the distribution of cases across the country. And then that data is also shared with the National Department of Health. The Modeling Consortium, as I already mentioned, will then look at and export that particular data for their development of their particular models. And of course, it's also linked to the DATCOV data as well. And we ultimately hope that in terms of the EVDS, that we will also have some linkage to that data as well, in order for us to better understand about the efficacy of our vaccines and breakthrough infections. So again, the data is accessible. It is accessible, and it's accessible at these particular websites. We'll share this particular slide set with you, where you can find these data in aggregated form. And of course, just bear in mind that we're reporting on what we receive on that day. So we're reporting on all the incident incident cases that arrive on that particular day. It may well be that the specimen has lagged in terms of when it was collected, sent to the lab, and tested. So there may well be lags. But there are approaches that we do adopt to try and ensure that we don't just have a skewing of that particular data, so that when you look at the epidemic curve, there's no marked skewing that you should note. And we do try and correct for that. And again, if you want to look at how the geocoding is done, again, there's another website that you can certainly look at. And if data is not made publicly available, it's because it's not easy or useful to do so. But again, you can certainly look at this particular website in terms of what is available, and or you can apply to access this through our so-called ARMS system that is part of the NHLS. So when we report this data, it's both from the public and private sector data to generate the daily numbers in terms of new cases, new tests, and present positive. But we do have challenges, and the antigen testing has been a good example where we do have experienced delays on that. And I'm sure some of you have seen that there can be delays up to 4 or 5 days. But that does not affect patient management, because an antigen test is done on the day, result is provided to that particular patient on the day, so that should not affect patient management. So we do certainly have challenges, and I'm sure you've noted that, but we certainly do try and correct for that as soon as possible, because we do take this data very seriously. So I think I've just reiterated these particular points, and I think that I don't need to go through this particular slide again, because I think I've emphasized that what data we do report, it includes both asymptomatic and symptomatic cases. So again, because that's just the nature of how this testing is done. But we can have problems again. If it's incomplete data, we will have to exclude some of that in those particular cases and try and correct that where we can. So thank you. And I'll take questions at the end for this. So I'm going to move on. I think it is Michelle.
Yes, thank you so much, Prof, for that insightful presentation. I think it's very important for the media and the public at large and those who hold interest with regards to COVID-19 to really understand the data flows of COVID-19. Right now, I'm going to hand over to our head of the Division for Surveillance and Outbreak Response, Dr. Michelle Groom, to take us over the case trends and the epidemiological analysis. Over to you,
Great,
Michelle.
Thanks very much. Okay, Adrian, do you mind just stop sharing?
Yeah,
and I'll be able to share. Thanks.
Okay, good.
Good morning, everyone, or afternoon. There we go. All right. Good. Well, thank you very much for joining our session. Just in terms of giving a little bit of a more in-depth discussion and unpacking the COVID epidemiology. I think we often do present the epi, but sometimes there's nuances that really need a little bit more discussion. So I think really these are graphs that you see in terms of our media releases and often in terms of our other epidemiology updates. And really just, this is the number of laboratory confirmed cases over time. And so we've just had over 3 million laboratory confirmed cases of COVID-19 in South Africa. I think just to note that there are some differences sometimes in terms of reporting via the date reported. As Prof. Purin's highlighted, so that is the date when we actually onboard all the tests from the private or public laboratories, and so are reporting those new cases on that day. But I think in terms of our epidemiology curve, I think it's more useful to actually plot it by the specimen date received. So this really gets rid of those potential lags in terms of the data reporting, where you may have, a day or two's lag in terms of when that case is reported. And so really looking at the specimen date received gives us a much more accurate kind of overview of when those cases were actually given. And we are usually would present a 7-day moving average and really just to be cognizant of the fact that these are including PCR and antigen tests, and that we know that there's under-reporting of the antigen tests. And I think in terms of these laboratory confirmed cases, just over 3 million South Africans with a laboratory confirmed case, but we know that this is an underestimate of really the number of people who've had COVID. Okay, so we think that we're underestimating this and really only diagnosing or laboratory confirmation of only 1 in 10 to 1 in 15 people who are actually having COVID-19 infections. And so while you're seeing this 3 million, I think you really just need to be cognizant that this is just, a small proportion of the true number. There's a lot of asymptomatic infection. There's a lot of people that don't test for certain reasons. We know that our testing itself, as Prof. Purin has outlined, does have some differences by province and private versus public sector, as well as just individual choices of whether to test or not. And I think if we look at our seroprevalence studies, really are showing that in excess of 70% of South Africans have actually been exposed and has, underlying immunity to COVID-19. So I think we use, and you'll often see the 7-day moving average. And the reason that we use the 7-day moving average is really to smooth out the curves. I think you must have noticed that over weekends, there's lower numbers of cases because, a lot of the labs aren't open. There are some of these delays in some of the testing. And so using the 7-day moving average does smooth out things and gives us a better indication of the trends. And I think, the trends in terms of epidemiology are really what's important rather than, today's cases compared to yesterday's cases. So it's much more useful to be able to compare today's cases, this week's cases to last week's cases. And so you'll see in our weekly epidemiology and testing reports, we are actually talking about the epidemiology weeks. And so really this is also just highlighting, in terms of the different ways we could report. And this epidemiology week is really just in terms of the Sunday to the Saturday. So when we're putting out our report, which will come out, today, what you're seeing is the data in terms of these weeks, which was reported up to this past Saturday. All right. And so there is a little bit of a delay in terms of the data that's coming out subsequently. But once again, it's the trends that are important. And I think you can really see that there's also differences in terms of the testing strategies between provinces and you can see Limpopo has consistently had very low testing rates. Gauteng and Western Cape have had much higher testing rates. And so when you're looking at the incidence, also just to interpret this, that if in some of the provinces like Limpopo have a very low incidence, but then once again, they've got a very low testing rate. And so there's lots of things that actually play into the different patterns that we're seeing. And so we can have a look at absolute case numbers, where you can see that Gauteng, because it's the most populous province, obviously has the most cases. And so, if we're looking at a daily basis and you see that 40% of the cases are from Gauteng, I think we would expect there to be more cases from Gauteng because there are more people in Gauteng. And then looking at the incidence where we take in the population, underlying population into account, you can see that you have a smoothing out of this. Look, Gauteng still has the highest incidence, but you can kind of see in that second wave, the incidence in Gauteng was lower. So I think just those subtle differences between case numbers versus case incidence, date reported, versus specimen date received, and when we report by epidemiology week and what these really mean. And overall then, just to highlight, we have seen a decrease in the 7-day moving average in the last week. And so there has been a decrease in the daily number of cases, and there's been a decrease in the weekly case incidence. And this has been particularly in 4 of the provinces. So we started seeing last week already a decrease in the Gauteng incidence, and this week we've seen a decrease in Northwest Limpopo and in Mpumalanga. I think age distribution is very, very important as well. And especially for this wave, we saw that the 4th wave started in the younger population and has now moved into the other age groups. And so you could see early on, we've had a very rapid increase in terms of all age groups actually in this wave. But initially, we know that the wave started in Gauteng, particularly amongst the institutes of higher learning. We then saw increases in those younger age groups particularly. And then these have actually decreased in the last week in all age groups except the older age groups. And so this is to be expected. If it starts in the younger age groups, the schools have now closed, children go home, the university students have now gone home. And so you do see this movement into the older age groups. And each wave has also had very different dynamics in terms of transmission. Our third wave was really the wave when schools were back, universities were back, people were at work. And we saw a very different trajectory to what we'd seen in some of the previous waves. The second wave last year was very much in the school holidays. People were traveling. And this wave has been a little bit of a hybrid in that we started while schools were still and universities were still, in session. And subsequently, we've moved into the holiday period. And so all these things do determine how much and in which age groups we have transmission of the virus. So the other one, the other metric we use a lot is the percent testing positive. And so this is really just the number of positive tests that we get over the number of tests. And we just multiply that by 100 to get the percentage. And so you could have the percent testing positive on a daily basis, which we put in our daily reports, or you could have the percent testing positive on a weekly basis, which is what we're putting out in our weekly testing reports. And so it's really useful to be able to look at these trends over time. So you can see over the last couple of weeks, we had very high testing, proportion testing positive in Gauteng. This quickly spread, to other surrounding provinces, started filtering down into the coastal provinces. And in this past week, you can see high positivity rates across most of the country, with some return to Gauteng to slightly lower positivity rates. And if we look over time, we can see Gauteng in this week has started decreasing in terms of positivity rates. And really all indications are that we've seen the end of that we've surpassed the peak of infections in Gauteng. We've seen a stabilization in Mpumalanga and Limpopo, and also a decrease in Northwest. And yet our other provinces are already still seeing high case numbers and high positivity rates, and are still very much on the upward trajectory. Also, just to highlight that when we're talking about the positivity rates, these are including PCR and antigen tests, and there are slight differences in the positivity rates, with slightly higher positivity rates in the PCR versus the antigen testing. And I think going forward, using the PCR test is more likely to give a slightly more accurate reflection, mainly because we know that there's a lot of underreporting of the antigen tests. And so, or you may have positive antigen tests which are reported more likely to be reported than the negative ones. And so you can really see in terms of going forward, we may well move to using the PCR tests only. I think just a quick update in terms of the Omicron variant. I think really just important that we're not sequencing all of our samples. So we sequence a proportion. And so it's very difficult to know exactly how many deaths are due to Omicron. We know that Omicron has overtaken from Delta in all of the provinces and is now dominating our sequencing. And so it's likely that the hospitalizations and deaths that we're seeing at the moment are due to the Omicron variant, but we're not sequencing everything. Also, just to note more from a technical point of view is that the Omicron variant has separated into different lineages now. So there are 3 different lineages. Similarly to Delta, we had over 100 sublineages of the Delta variant. And so this is to be expected. And obviously, we will be monitoring this. These reports are all available on our website. And really just to show the dramatic, takeover by Omicron of Delta, where in October, Delta was really the large proportion, making up the large proportion of our sequences. In November, this, really took over. And at the moment, really dominating 95% of the sequences now from December. So I think really we are seeing a decrease in the daily case numbers and the percent testing positive in the Gauteng province. And really we feel that, this has persisted for over a week and that we are past the peak in Gauteng. There has been a leveling off in Limpopo, Northwest and Mpumalanga in terms of the positivity rates. And we are seeing decreases in the 7-day moving average. But we are still seeing increases in the other provinces. So coastal provinces as well as Free State and Northern Cape. We know that Omicron variant is dominating all the sequences. It has now been detected in all provinces and likely to take over from Delta in all of the provinces. And I think just to be aware, obviously this is encouraging and quite optimistic in terms of the decreasing trends in case numbers. But I think we really do need to be cognizant that this is from last Thursday. It was a long weekend. People are now traveling, and there may be changes in terms of the number of people that may be testing. And so some of the lower numbers may be due to the holiday season that we're in. And I think very important to monitor the percent testing positive, as this gives us a good metric, and which isn't taking into account the overall case numbers, but it's the proportion that are testing positive in those that are accessing testing. Just to remember, we're in adjusted level 1 lockdown at the moment. We've managed to avoid any increase in restrictions, and I think are watching our hospitalizations very closely, and Dr. Jasat will give some more information on that. And I think we really almost 2 years in, we know what works. We have definitely seen effectiveness of our vaccination program, mask wearing, social distancing, and limiting our large gatherings. So I think I'm going to stop there and then hand over to Dr. Jasat. Let me just quickly stop sharing.
Thank you so much, Michelle. I see we already have a number of questions from the media colleagues, which we will answer as soon as we are done with presentations. And I think your presentation is very insightful, and the decreasing trend is very positive. And I like that you caution that we still need to vaccinate, and we still need to practice preventive measures to see a further decrease in these case numbers. Dr. Jasat, if you can please, as I wrap up, just pull up your presentation. Dr. Jasat will speak to our hospital surveillance for COVID-19. Dr. Jasat, over to you.
Thank you, Sarah. So I'm going to follow on from Dr. Groom's presentation to show you some data from hospitalization data from our DATGov surveillance system. And because we have a few more weeks data, in the previous weeks I was sharing data for Gauteng specifically, and this week I'll share data for the country. So many of you may know that we established DATGov in March last year as a hospital surveillance system. Over the first few months, we got more and more hospitals on board, and by about July, DATGov was adopted as the national hospital surveillance system. So we currently have 407 public hospitals and 259 private hospitals that report to DATGov daily, and this represents complete coverage of all the hospitals in South Africa that do admit patients with COVID-19. Throughout the wave, we've been monitoring the numbers of admissions in the public and the private sector. And in around week 45, 46, we started to see increases, first in Tshwane and Gauteng, then spreading to other provinces. But when you look at the South Africa picture, you can see the increase in hospital admissions in this fourth wave was similarly across the public and the private hospital sector. And this is the admission incidence risk per 100,000 admissions by province. And what's very striking here is that when you look at the picture in the first, second, and third wave, there was this protracted period of admissions and cases rising in one province, and then a few weeks later in another province. And I think over 3 months, we saw this evolution of the waves in each province. However, in this fourth wave, you can see increases in all provinces almost simultaneously. First Gauteng, and within a week, all the other provinces began increasing, and a similar increased trajectory to similar levels as well. And so I think that this fourth wave has seen a very rapid increase in hospitalization across all provinces within a few weeks. We looking at that differently, we look at the week-on-week increase in hospital admission and cases, and you can see that the case increase week-on-week rose above 500%. So that indicates a very rapid transmission of infection in the communities, whereas hospital week-on-week increase rose to just under 300% at its peak. Of course, this is still changing as admissions continue to increase in some provinces. But what's interesting here is that the week-on-week increase in hospital admissions was not as high as what we saw for cases. Just looking at this in another way, we compare the 7-day moving average for cases in blue, admissions in red, and deaths in gray as a percentage of the third wave peak that was dominated by Delta. And nationally, while you see cases are peaking at a higher rate or have reached a higher rate than they did in the Delta wave, admissions have reached probably half the rate that they reached in the Delta wave, and deaths have not increased much when compared to the Delta wave peak. What you can also see from this graph is that in the third wave, you can see that admissions have a week lag to cases, and deaths have about a 2-week lag to cases. So we always allow for some time, because we know that once a patient becomes infected, there is a lag period before patients then may need to be hospitalized, and then a lag period before they may have an outcome from the hospital. And so we always interpret our death and severity data with caution, because we know we need to allow for some time for these outcomes to develop. Here is some data looking at the percentage of COVID admissions that were required supplemental oxygen, and you can see the data for the public and the private sector. We always see an increase in the peaks of the waves. However, in this wave, in both the public and private sector, we haven't seen a trend towards increased requirements for oxygen in hospital amongst the patients admitted, and the trend still seems to be downwards in the last 3-4 weeks. This is the same kind of graph, but it's looking at the proportion of patients on invasive mechanical ventilation. And similarly, while we saw increases in the previous waves, in this wave, we've seen no increase in the number of or the percentage of admissions who needed to be ventilated in either the public or the private sector. And this percentage is at a very low level compared to previous waves. Again, similarly, this is the percentage of patients who needed to be treated in a critical care ward, which is ICU or high care. And you can see there's more patients who get into an ICU or high care bed in the private sector because there's more capacity compared to the public sector. But in both the public and private sectors, over the last sort of 4 or 5 weeks, there's a downward trend in terms of the percentage of patients who are treated in a critical ward. And we haven't seen an increase with this fourth wave nationally. And then finally, this is a case fatality ratio by week for the public and private sector. And very striking is that really in each of the 3 waves, we've seen an increase in the public and the private sector in mortality. And this is in-hospital mortality. So it's a percentage of COVID admissions in our hospitals that have died. And we know that at the peaks of the waves, when the hospitals are under strain, there is likely to be more mortality. There are more constraints for patients getting beds, getting ICU beds and ventilators. And so we do see more mortality during the peaks of the waves. However, in this fourth wave, we've seen a slight increase in case fatality ratio, but not the kind of increases that track with the cases and admissions that we've seen in the previous wave. And the proportion of mortality or the case fatality ratio is actually quite low in the private sector, lower than it's been at any other point in the pandemic. In the public sector, a little bit higher, but also lower than it's been at any other time in the pandemic. We also did some analysis comparing severe disease in the early 2nd, 3rd, and 4th wave in South Africa. The way we calculate severe disease in our DATGov data is any patient who had a respiratory distress syndrome, who needed oxygen or ventilation or heart support, who was treated in ICU or high care, or who died, is categorized as severe. And we know that early in the wave, there is a bias around, maybe less severe patients being admitted, less mortality, because it takes time for those outcomes to be accumulated, because there are more beds available, and a lot of patients may be admitted who are mild, whereas later in the wave, they may not be admitted. And also in the early part of the wave, we have a lot of incidental testing positive. So patients admitted for other reasons who are tested, and they test positive even though they have no COVID-19 symptoms. So because of some of these limitations of the data, our analysis includes only patients who already had an outcome from their admission, and it excluded the patients who were still in hospital. So we looked at the first 4 weeks of the 2nd, 3rd, and 4th waves in South Africa. And this is the percentage of COVID-19 admissions in each of those 4-week periods for the 2nd, 3rd, and 4th wave. So one thing that's striking is that most admissions in the 2nd and 3rd wave were in older people, 50s and 60s. However, in the 4th wave, the bigger proportion of admission was in younger people under 40. However, when you look at the proportion of admissions over cases, the percentage of cases admitted, it was similar for all age groups and even for those that were younger. And so I think that this change reflects just a huge proportion of cases in young people, and a larger proportion of the admissions being in younger people in the fourth wave than in the second and third wave compared to older people. We also looked at the average length of stay. This is the median length of a patient's stay in hospital. In the second and third wave, you can see the average was around 9 or 10 days. It increased for older people. But in the fourth wave, the average length of stay has been around 3 or 4 days and has been lower in the fourth wave for every age group compared to the second and third wave. So this really shows you that the patients who are admitted in the fourth wave are staying for a shorter duration in hospital. And finally, this is the percentage of patients who've died. And this is in the second and third wave. You can see that for all waves, there's a higher proportion of deaths in the older age groups compared to the younger age groups. But what's really striking is that in the fourth wave, there's a lower mortality this is a percentage of severe disease. And so there's a lower proportion of severe disease in the fourth wave in gray compared to the second and third waves for all age groups. And this is a mortality, so this is an in-hospital case fatality ratio. It increases very dramatically with age, and so it's very low for children, and around for people over 80s, the mortality is over 40% of those who are admitted in hospital, and that was a similar picture in the second and third wave. However, in the fourth wave, for a similar period, the case fatality ratio is lower for every age group. So this is just a quick snapshot of cases, admissions, and severe disease and death in South Africa across the 4 waves. And what I want to point you to is in wave 4, we had a huge number of cases in the first 4 weeks compared to the previous 4 waves, over 366,000 compared to wave 1, 2, and 3. In terms of the number of admissions, you can see that in wave 4, it was around 21,000, whereas in wave 2, about 19,000, and in wave 3, about 16,000. So that huge increase in cases didn't really translate into a huge increase in admissions. And when you look at the proportion of cases admitted, or the percentage of cases admitted, in wave 1, it was 13%, in wave 2, 16%, in wave 3, 16%, and in wave 4, 6%. And so the percentage of cases that are admitted is much lower in wave 4 than it's been in previous waves. The percentage, as I showed you in the graph earlier, of patients with severe disease was 27% in wave 4, whereas it was 52% in wave 2 and 66% in wave 3. And the percentage of patients who died was 6% in wave 4, whereas it was 21% in wave 2 and 22% in wave 3. And as I showed you, the median length of stay was 3 days compared to 5 and 6 days in the previous waves. We do not have complete data on vaccination because our data is not linked to the national vaccine database, but we do have some self-reported vaccination data. And across South Africa, for 5,439 admissions, which is 28% of all the admissions reported in this period, the proportion of unvaccinated individuals was around 83%. And so that's higher for younger age groups, and a bit lower for those who are over 50. But on average, most patients admitted to hospital who had data on vaccination were unvaccinated in this 4th wave. When we look at the deaths that have occurred since 7th of November in South Africa, out of the 20,000 or so admissions, 807 deaths have been reported across all provinces, with a case fatality ratio of about 4%. Now, the reason for admission was known for about 637 patients. In most of them, it was said to be COVID symptoms, but for 19%, there were other reasons for admission. And in terms of comorbidities, for those that we had data, 76% had a medical condition. On the right, you can see the number of deaths by age group, and you can see most deaths were in those over 60. Now, in terms of the vaccination status of those who've died, for those that we had data available, which is 309 patients, 40 or 13% were fully vaccinated, and 269 or 87% were unvaccinated or not fully vaccinated. So a majority of the deaths that we had data for that have occurred in South Africa were among people who are unvaccinated. And just to provide a bit more information in terms of the types of vaccines and the time from vaccination to admission, for J&J, there were 9 patients who died after receiving 1 dose. None of them had received a booster. And the time from vaccination to admission was about almost 4 months. It ranged from 87 days to 143 days. With Pfizer, there were 28 who had gotten a first dose and 35 who had gotten a second dose, and none had gotten a booster. And again, similarly, 4 months was the average time from vaccination to admission. And so very few people had died within 3 months of being vaccinated, just 5. And then 7 died within 3 or 4 months of vaccination, 12 died 4 or 5 months after vaccination, and 3 died more than 5 months after vaccination. And so, I think these are important data in terms of understanding the proportion of deaths that were unvaccinated, and some of them having a longer duration from vaccination to admission, suggesting, as we know, that there is some waning of immunity, and this may play a part as well. Just in summary, we are seeing hospital admissions in Gauteng peaking, and some signals in Mpumalanga, Northwest, and Limpopo towards decreased admissions, and this is similar to the case data Dr. Groom showed you. However, other provinces still have rising numbers of admissions. In terms of severity, there's a lower percentage of hospital admissions, a low percentage of cases who've been admitted, and a lower percentage of admissions who have died. And there are signals towards lower severity amongst those admitted and shorter lengths of stay. And I think it's important to point out that the lower risk of or lower proportions of severe disease we're seeing in the fourth wave could be due to a number of factors, including the level of prior immunity from people who've already gotten vaccinated or had natural infection, or it could also be due to the intrinsic lower virulence of Omicron, but we need more studies to be able to unpack these things. But I think the messaging still remains clear that during the wave, people should use all non-pharmaceutical interventions, wear masks, avoid social gatherings, and I think especially important, we know that vaccinations work and they do protect against severe disease, and so people who haven't been vaccinated should get vaccinated, and when booster doses do become available, those who are eligible should get booster doses. Thank you so much.
Thank you so much, Dr. Jasat. You've shared very generously with us, and I think you've really set the tone for the trends with regards to in-hospital mortality as well as hospital surveillance. If Prof. Cheryl Cohen can put up her presentation as we move over to her presentation on the early assessment of the severity of the Omicron variant. I think personally, I've received a lot of queries from media colleagues with questions pertaining to this. So I'm very glad to have you here, Professor Cohen. Over to you.
Sorry, I'm suddenly having a unexpected jumping around of my screens. Let me just. Can you just tell me, have you got the full screen view?
Yes, we do. Thanks, Prof.
Okay, so just to tell everyone, I've got 2 screens and it's on the side, so you're going to see the side of my face, for which I apologize, but I think it's better than restarting it. So thank you very much for the opportunity, and it's great to see so many people present. Just to say that my presentation has a slightly different focus from the others, in that the first 3 presentations really spoke more to our surveillance at the NICD, and these data I'll be sharing are also derived from a surveillance program that I'll tell you about, but in fact they pertain to a research paper, and the preprint has been posted on Medix RIV, the preprint server last night. So essentially the data are available, and there's much more data available online. And this study really, it's entitled Early Assessment of the Severity of Omicron Variant in South Africa. And I think it addresses, really one of the key questions that everybody wants to know, is Omicron less severe than previous variants. Just to point out that the first author is Nicole Walter, and then a number of other co-authors, and this is a collaboration between the NICD, the National Health Laboratory Service, Lancet Laboratories, and also the NGS SA network. So just as background, we know that the Omicron emerged on a setting of high population immunity. It's estimated that 60 to 70% of people in South Africa have had a previous infection, and in addition, we have the highest rates of vaccination in Africa, and we know there was another paper published that when Omicron emerged, one of the reasons it spread so rapidly is because there is a degree of immune escape. In other words, immunity from previous infection provides less protection against Omicron than it did against, for example, Beta and Delta. And so in a sense, that's the reason, one of the main reasons why we saw this very rapid spread and the very rapid increase and decrease that Wasila and Michelle and others have already presented. But one of the key questions is really, yes, it's spreading faster, but is it less severe? And Wasila's already presented, and of course those data have been shared regularly, the very encouraging data from the DATCOV program that point strongly to a substantially lower severity in the Omicron wave. I think there's some limitations of those data. However, one of them is that we're really looking at periods of time. There's not an actual confirmation of did the person have Omicron or not. And it's so they're more sort of trend analyses rather than individual analyses. And then also there is that delay, and that not everyone might have, who will experience a severe event, might have experienced it yet. And so in this study we try to address those two questions. Firstly, though, just to say we in order to do the study, we took use of something that happened with Omicron that allowed us to be able to rapidly tell who was an Omicron case and who wasn't an Omicron case. Many of you may have heard of this. What it is something called S gene target failure. So there are lots of different PCR tests for COVID, but one of the tests we use, which is called the Thermo Fisher Tac Path test, looks for three different targets: the S gene, the ORF1, AB, and the N gene. And because I'm sure you all know, the Omicron virus has a lot of changes in its genome. There's a deletion in that S gene target on this assay. And so when people have Omicron, if you test them on this assay, they come positive on the ORF and the N gene, but they are negative on the S gene. And this is a very classic picture, and it's called the S gene dropout. And we've shown that it's highly specific for Omicron, this S gene dropout. And so we were able to harness this S gene dropout, which is really a marker for Omicron, to then look at the association on an individual level between people who have Omicron infection versus infection with other SARS-CoV-2 variants. And this was all done by a new surveillance program that NICD set up actually as a response to the previous waves. It's called DATCOV Gen. And what it does is it basically links a whole lot of different databases to be able to, with the intention, and we did this before the Omicron wave, so that we could have a system to rapidly be able to look at severity should there be a new variant. And so we take the data from the national case line list, the lab testing data that's produced by the NHLS, and also in this case the Lancet laboratories. We take data from our genomic sequencing databases and from the DATCOV hospitalization data, and many of these will have already been presented. And we link all of these together so that we can create databases where we have information on the actual variant that the person had, whether it's through the sequencing database or through this S gene target failure. And then we also have their detailed clinical information from these other databases. And using that, we can then compare on an individual level, and knowing the period the person was infected, were they more severe or not? And so basically what we did once we'd linked all these databases together is we did two comparisons. The first comparison is we looked in the time from the 1st of October to the end of November, so when Omicron was emerging, and we compared the people with Omicron, and we did this by saying whoever had an S gene target failure, so we only included people tested on this Tac Path assay, to those who were not an S gene failure and therefore didn't have Omicron in the same period. And we looked at whether those two groups of people, so between October and November, were more or less severe, whether they had Omicron or not. And then the second comparison we did is we again took the S gene target failures in the Omicron period, and we compared them to individuals in the Delta wave who actually had sequencing data, and we knew them to be Delta. And then we did those two comparisons, and I'll tell you the results now. So just the first thing that comes out of our data is really, and you've probably seen some of this data, Omicron really took over and emerged extremely rapidly compared to other variants. So this is just the epidemiologic weeks on the x-axis, and the percentage SGTF is really the percentage Omicron. And you can see there, Gauteng came first in the purple within 2 weeks, almost complete replacement. And the other provinces were even faster. So the other provinces started a bit later, but then it's almost a vertical line, within 1 week. There was almost complete replacement with Omicron, and by the end of November it was really 98% of all cases on the TAC path assay were coming up as this S gene target failure. So very, very rapid replacement, and it's this period from 1 October to 30 November that we used for our first comparison of severity. So this is the results of that first comparison. Essentially, so what we did in the same period, we looked at people with Omicron to those without Omicron, and we found that in this period there was an 80% reduced chance of being admitted to hospital if you had Omicron versus not having Omicron. And however, when we looked amongst people admitted to hospital, we didn't see a significantly lower chance of developing severe disease. In fact, the point estimate was 0.7, so there may have been a slightly lower risk of severe disease, but it wasn't statistically significant. So in the same period of time, people with Omicron less likely to be admitted to hospital substantially, 80% less likely, but amongst people admitted to hospital, not as strong a signal on the reduction of developing severe disease given hospitalization. And Wasila explained the criteria that we use for severe disease. The second analysis we did was we compared in the purple the people with Omicron or S gene target failure in October to November to all the people we had in our database with sequencing data of Delta infection. And in this analysis, we just looked amongst admitted people, and we found that amongst people admitted to hospital, those with Delta, those with Omicron, were 70% less likely to develop severe disease compared to Delta after controlling for other factors. So I think both of these data sets really point to less severity when we look on an individual level. And then we did one more analysis, and this was not really about severity, but it was really looking at the viral load of people who are infected with Omicron. So we know it's much more infectious. One of the reasons could be that actually people with Omicron have got more virus in their nose, and so they're more infectious. So the way we did this, we used another lab proxy, something called the cycle threshold value, which has been shown to correlate very strongly to the amount of virus in your nose. The lower the cycle threshold value, the higher the viral load. And what we found is that when we compare the early Omicron period to the early Delta period, significantly higher CT values, so lower viral load in the Omicron period, suggesting that in addition, people with Omicron have this higher viral load potentially in the nose, which fits with what we see with this very increased transmissibility. Our study did have some limitations. We could only identify Omicron on people with this particular test, and that was in certain provinces. And we used this target as a proxy, but in the period, it was highly specific, in fact, for Omicron. So we feel that they were Omicron. And then what Wasila mentioned, the analysis was done early in the third wave, and the early patients may be slightly different. Importantly, though, a strength of our analysis is we included patients diagnosed up to 30 November, but we actually included their outcomes as to whether they were admitted or what happened in hospital with data up to the 21st of December, so yesterday. And so what that means is that people included, we allowed 3 whole weeks for them to develop an outcome. And we know from DATCOV that most people will actually either be discharged within less than a week, and severe cases, in fact, get discharged even faster. And in fact, we had full discharge data on 80% of people. So we think that this limitation of not enough follow-up, in fact, in our study now, really the data are coming to be quite robust. The majority of people have a fully ascertained outcome, and we're relooking the data every week, and the point estimates are staying exactly the same. So we aren't seeing, it seems to be robust. We will continue to follow it up, but I think we're not really seeing a suggestion that this is going to disappear. And then the vaccination data are somewhat limited. So just in conclusion, the main results, Omicron introduced very rapidly took over other variants. If we look at in the same period, the Omicron patients had an 80% lower chance of admission, but given admission, not really significantly lower risk of severe disease. However, when we compare Omicron to the Delta in the previous waves, amongst hospitalized people, significantly less reduction in progression to severe disease, 70%. And this, of course, correlates very well with what Vasila has just shown you with the DATCOV data. So all the data together are really pointing to a very consistent picture of a reduced reduction in severity in South Africa. I think what's important, as Vasila said, is we can't tell from this data how much is from vaccination and how much from previous infection and how much is about intrinsic reduced virulence of the virus. And that's because our data on vaccination are incomplete. Vasila explained that. And also that most previous infections are not diagnosed in South Africa. But I think what we can say is that in South Africa, this is the epidemiology. Omicron is behaving in a way that is less severe. And that likely this is generalizable to other countries in the region in sub-Saharan Africa, which have a similar picture with very high levels of previous infection. I think what is unclear is how, whether the picture will be similar in countries where there are high levels of vaccination, but very low levels of previous infection. So where the baseline epidemiology is different. But I think compellingly together, our data really suggest a positive story of a reduced severity of Omicron compared to other variants. And again, just to acknowledge the many, many different collaborators on the study. Thank you.
Thank you so much, Professor Cohen, for that insightful presentation. It's quite a lot to digest. So I'm seeing a lot of questions from the media. So we're going to try and tackle as many as possible. I'm just going to request some of the speakers, if possible, to respond directly on the chat while we tackle other questions, just so that we make sure that we are able to answer everybody. And I see Dr. Michelle Groom has already started responding to some of the questions. If Prof. Puren and Dr. Vasila Jasad are able to do that for us as well, I'd be very, very grateful. So I'm just going to read some of the questions that we have received from the media. We've got a question from Frank Louis from the paper. This question is for Dr. Michelle Groom and Professor Cohen, and it says, as you just explained, considering the newly reported cases in South Africa are declining, does that mean South Africa had approached its peak? And what is your interpretation of the surge of new cases and patients hospitalized in Europe and the US? Will they be different from SA and Y? So I'll allow Prof. Cohen to go first, and then Michelle, you can add as well. Thank you.
Okay, thanks. Michelle had unmuted, but so I think it's difficult to say whether nationally the cases are going down yet. So remember, the initial increase was in Gauteng, and Gauteng is a very big province with a lot of testing and a lot of cases. And so we see the cases coming down now, but we know that Western Cape, KZN, and other big provinces have not necessarily peaked. So I think we can certainly confidently say Gauteng is going down, and some of the other provinces around Gauteng. But I think it's a little bit longer to wait to see what happens nationally. In terms of the increase in cases in Europe and North America, I think one thing is they to some extent have sort of mixed waves, Delta and Omicron. And I think it goes to what I was saying before. I think that there are big differences in those parts of the world. So several that I can mention. One is it's winter, right? And respiratory viruses spread more in winter. The other is the previous immunity in many of those settings is as a result of vaccination. And in South Africa, the majority of immunity is as a result of previous infection. Other data suggest that for all the other variants, certainly, previous infection was more robust against, in protecting you against reinfection compared to vaccination. So in fact, infection is a strong immunity. And it could be that people with vaccination may have less protection against severe disease with Omicron. We don't know that yet. And then the last thing is really important, the age, which I didn't mention because I was going quickly. The age distribution of those populations is very different. Many more older people than in our setting. Michelle, do you want to add?
Yeah, I think you've covered it, Cheryl. I think it's very difficult to extrapolate our situation to other countries. I think there's lots of differences, and I think we just need to be cautious. And definitely in terms of the case numbers, I think we are in this holiday period. And I think, we just need to be cautious in terms of the absolute case numbers coming down, that, if you're traveling, maybe you're not going to go and test, as you would have done at home. So I think we just need to be careful and not become complacent, saying, oh, well, the fourth wave's, been quick up and quick down. So I think lots of people have also left Gauteng. And so we need to keep a close watch on other provinces. KZN had a relatively small third wave. And so we don't even know whether what's happening in Gauteng is going to translate into what happens in the other provinces. So I think really just, need to take, the data day by day and week on week. Thanks. Over.
Thanks, Michelle. And I think you kind of answered the next question from Masha. So I don't know if you'd want to elaborate further. So Masha from Mail and Guardian is saying, are we likely to see the same outcomes of less severity and hospitalizations from future variants like we are seeing now with the Omicron?
Yeah, well, it's always hard to predict COVID, but I think from what we're seeing is that, after this wave, we would have even more exposure. It's a very transmissible variant. There's, those that have been infected before have probably, a lot of those have been infected again. And so they would have been boosted. And so we're in the situation where, people have been have had prior infection, they have had vaccination. And if we increase our vaccination rates, that will provide a boost. And so we're likely going into a next wave in a better position with even higher seroprevalence from, and immunity from both natural infection and vaccination. And so I think, I think it's the whole move towards the virus becoming more what we talk about being endemic, in that we will likely see these waves, but we would hope that they would become smaller and smaller as the overall population protection increases. I'm not sure if Cheryl wants to add.
No, I agree. I think as long as, which the data suggests, the key thing is that the more and more people have vaccination and or previous infection, the more people that get a disease are actually breakthrough infections. And as long as what has held very strong so far, previous immune exposure to vaccination or infection protects against severe disease, the severe outcomes, we would expect to see that trend. So it would only be in a very rare, unlikely, I would say, improbable situation that there was a variant that had so much escape. And I would say that is relatively unlikely. We've seen from previous pandemics, flu, etc., that this is what has happened in the past, I suppose, as well. That with time, especially now 2 years in, you start to see the population immune effects kicking in terms of attenuation of severity.
Okay, thanks, Prof. Cohen, for that. I'm going to read a question for Prof. Pure, and if you could please put your camera and unmute your mic. This is with regards to health-seeking behavior. This question is asking if we are likely to see, it's from Miriam Issa, could the lower case numbers reflect lower testing rates during the holiday season? So I think this question is around health-seeking behavior during the holidays. And I think it also has to do with accessibility and availability of primary health institutions and testing laboratories.
Yeah, I think it's similar to what Michelle had answered earlier, in fact, that people are traveling. They may not necessarily present for testing. However, the access to testing is ongoing. No laboratories are closing, as far as I'm aware. Antigen testing is also should be widely available as well. So I think having that access, I think, is really important. But I think it really depends on people's behavior, whether or not they are going to seek that. But I think our real focus, I think, is what Michelle and Cheryl have indicated. Although, yes, we are interested in seeing what is actually happening around the country in terms of the numbers tested. I think our main focus really still comes back to what's actually happening to our hospitals in terms of what levels of serious or severe disease are we seeing in terms of hospitalizations and deaths, and is that related to the particular immune profile, whether it's previous exposures to natural infection or vaccine. These are the key questions I think that we're currently focusing on, as well as ensuring that our hospitals are not overwhelmed in terms of numbers. Thus far, when we look at what Wasila has presented, we certainly see that is not the case. So yes, one would want to encourage people to test, especially if they are unwell, because I think, again, I think we've seen in previous waves that people really present late. So again, if you are in those scenarios of having signs and symptoms of disease that needs attention, please go and test.
Just gone 7 minutes past 1 p.m. Central African time on day 636 of